overview of the agenda, which I think most people have received. We will start with Dr. Anant Sachdeva, who will go over using QFIT in primary care and again the lower GI pathway changes. We've then got Dr. Brian Nicholson from the Nutfield Department of Primary Care, who will go through the elements of the FIT testing for us. And then we hopefully will also have Mr. Jeff Lim from the GWH, along with Hazel Craig, who will discuss the impact of the pathway changes that there has been on secondary care so far. Now, obviously, they're at the Great Western Hospital at Swindon, so but I'm aware we also have other acute trusts on the call as well, who will be able to answer, I know for Salisbury and RUH. We also, for the Q&A session, do have Dr. Amelia Randall, who will also represent the SWAG Cancer Alliance. So hopefully we've got enough people to answer most questions. Now, if for any reason we don't get through all the questions, obviously you can put them in the chat and we'll try and circulate them later. If you have emailed Daniela to get onto this webinar, then we should have your email address. But if there's any doubt, please just pop it into the chat so we can send you slides and all the information at the end. So we'll start off with Anant with your talk, please.
Karen, thank you so much. Thank you for this opportunity to discuss the Thames Valley Cancer Alliance FIT pathway, which has been going on since July, but we thought it'd be worth refreshing and answering a lot of the questions. And by the way, Karen, I love your accent. It's always really nice to hear your accent, and it's quite musical in a way. And next slide, please. So nationally, we saw a drop of around 75% in the number of two-way referrals for suspected cancer, and this was at the time of the peak. But we all know that with workload increasing and lots of capacity issues, there's a lot of a challenge in primary and secondary care for suspected cancer referrals, and specifically for lower GI. And really, the point about this new pathway is that we are suggesting and have suggested the use of FIT for testing in suspected lower cancer referrals, which actually helps to plan the actual capacity issues and prioritization of the patients to be investigated. Next slide, please. So we developed a lower GI pathway using FIT back in the summer, and we're working through this since the pandemic. And we worked this in collaboration with a variety of teams to make sure that we were actually getting it right. In particular, we worked with the clinical advisory group for the Alliance and academic leads, especially from Oxfordshire, and you'll be speaking to one of the authors of one of the papers who has informed this pathway. And so therefore, we wanted to make sure that the pathway was evidence-based. We also worked with commission leads in making sure that as critical friends, they were making sure that we were getting it right between primary and secondary care, and in particular managing the patient safely. The local medical committees had an opportunity to be supportive of the stance we were taking and making sure that primary care was doing the right thing for patients. Clearly, primary care engagement is crucial, and since the start of this pathway, we've had a variety of feedback, and today is an opportunity to feedback to us again as to how the pathway is going since its inception and implementation. Next slide, please. So this is the pathway, which I'm sure you've seen before. The green bit, which was at the top right at the beginning, was about screening, which had paused. But as you know, screening has restarted again in terms of bowel cancer screening. But this is the pathway here for adults, which is the urgent suspected pathway for GI cancers. And just talking through it from left to right, you can see that when patients present with bowel symptoms, which are in concordance with the NG12 guidance, which includes abdominal pain, change in bowel habit, weight loss, iron deficiency, anemia. We are suggesting and have suggested, according to the guidance, that the GP should arrange a FIT test if available. Use the knees because eGFR is really critical. anemia status and ferritin status together with the celiac blood test. So this is in particular about some of the NG12 symptoms. If a patient has an abdominal lump or a rectal anal lump or unexplained rectal bleeding, and then it is suggested that the GP arranges, use these hemoglobin and ferritin levels, and then actually refers into the 2-week wait referral pathway. Once the FIT test has been carried out, the GP is to assess the FIT result before referring to secondary care. And we'll go into reasons why in a second. But if the FIT result is over 10, then we're suggesting that people are referred straight into the 2-week wait referral pathway, including within the referral, in the usual way for any referral, a full history, any frailty and performance status scoring, and any COVID risks. The patient is then triaged by secondary care and prioritized as to whether they need to have any further investigations, either imaging or straight to test from a colonoscopy point of view. And that's a secondary care consideration to prioritize. Going back to FIT results, if the FIT result is less than 10, our pathway actually says that the less than 10 means that there is less likelihood of cancer, and there is some evidence to suggest that. And we're suggesting that patients should be safety netted and reviewed in 2 to 4 weeks. If, however, the patient is still, if you're still concerned about a patient, then we're suggesting that you seek advice from the specialist provider, either through direct contact, advice and guidance, and various other pathways, which we'll hear from in a moment. But the important thing here is that less than fit probably needs to exclude other pathology. I'll go into a bit more detail in a little while. However, our pathway also says that if you're still clinically concerned with progressing or alarm symptoms, weight loss, abdominal pain, or progressive bowel dysfunction, then you can still refer in on a 2-week wait referral form as a 2-week wait referral. So really, at the end of the day, we are thinking of the patient using FIT as a tool to help us prioritize patients, and secondary care should actually be managing the patients. Next slide, please. Shows that should we not be doing plain rectal bleeding? Well, I would suggest that FIT can be done for any patient with bowel symptoms, but if it is frank bleeding, and I'll go into a bit more detail on one of the slides, there is some evidence that actually you don't need to do FIT. So yes, you can actually refer in for unexplained rectal bleeding without FIT. So I mentioned safety netting, and safety netting is absolutely it must be focused on balancing risk and made between the patient and clinician. So we require really through safety netting to put its systems in place and document the advice given and the actions taken during COVID and following COVID. There are various templates available which you can adopt so that can be on and recalled, and there can be a notification of delays. But critically, it's really important that you include the patient and they understand what the next steps are following your advice, assessment, and consultation. And there have been instances whereby the patient contact details aren't up to date, and therefore there's been delays in contacting the patient. So we're advising really that we check that the patient understands what's going on and making sure that their contact details are correct. CR UK have a lot of information on safety netting, which you can find from the CR UK website, and you can see an example of this on the right-hand side of this slide. Next slide, please. So safety netting is key and very important to follow. I'm sure you're all well versed in this, but in particular for GI, ensure that other non-gastrointestinal pathology is excluded. So the symptoms may be relating to other pathology and not just gastrointestinal. It could be renal, gynecological, or peritoneal in some respects. And so therefore, when FIT is less than 10, with a low probability of GI cancer, we need to make sure that other causes have been excluded. And don't feel completely reassured with less than 10. We must make sure we understand what the symptoms are due to. Lower GI cancer needs to be excluded when there is the presence of a palpable mass and iron deficiency anemia. And these are really critical things that need referral and advice from secondary care. So we've also said that don't delay and make sure you review the patient within 4 weeks and make sure the patient understands that. Next slide, please. So review is critical in all consultations, as you all know. And if the patient continues to display alarm symptoms, concerning symptoms and signs, then we are suggesting that you can refer or ask for advice and guidance. And Mr. Lim will be talking about the advice and guidance processes in your area. Now, there is no data to support repeat test. The patient has persistent or worsening symptoms, and I would be suggesting that you refer or ask for advice regardless of the FIT result. And that is really important, that if a patient is getting worse, then actually seek advice. Why repeat a test? Get some advice. And apologies for the pun here, but never ignore the gut feeling. You know, GPs are very good and clinicians are very good at thinking there is something going on here that I must look into. So if there's still concern or uncertainty and doesn't fulfill the pathway, please seek advice. Refer to your local pathways. If you have a rapid diagnostic service, then refer to that. Or really, if there are really alarm symptoms, then please refer under the suspected referral pathway. Next slide, please. So the benefits of this approach is for patients and for clinicians, really. And most importantly, it's about the patient experience, the quality and timeliness of the referral. So we feel that FIT provides a high level of reassurance for patients with negligible results and improved access to services for those who are at high risk. And critically, and I keep repeating this, there is a reason why the patient's got symptoms, and alternative pathology is not to be missed. Because those symptoms could relate to non-GI cancers. For GPs and clinicians, better prioritization and triage and timeliness of the assessments. National guidance, including the BSG, cite FIT as an effective and key diagnostic test for prioritization. And there are a number of people who have had their 2-week wait referrals suspended due to COVID-19, and FIT enables those at high risk to be brought into the trust for urgent investigations when required. And again, alternative pathology is not missed. One thing that we've found recently is that when a FIT level is positive, it actually motivates patients to attend for their assessment. So when you do a FIT test, it is very important to advise the patients. They now have something, rather than just a doctor sending me for a quick checkup, they now have a test, which actually means that there is some urgency in assessment. So it's quite important to do the FIT test as well. Next slide, please. So I think I've rushed through quite a lot of information there, which I'm sure you're all aware of, but this is just a sort of reinforcing message. And I guess really, if there's any questions, we can take them later on or in the chat box now. Karen, I think the next speaker is over to you. I think it's Brian.
Yeah, perfect. Thank you. So if anyone does have any questions, please pop them in the chat box, but we will have a moment at the end as well if there's any further questions, particularly for Anant. So next is Dr. Brian Nicholson. I'll let you take the floor, Brian.
Hi there. So yeah, I'm Brian Nicholson. I'm a GP based in Oxford. I work in the primary care department doing research about cancer diagnosis, and I'm the GP Macmillan facilitator with the Oxfordshire CCG. So really, we've been lucky to be working on FIT testing over the past few years, having taken it on quite quickly in Oxfordshire following the 2015 guidelines. So we just wanted to talk to you about what we've learned through analysing the data of the data from patients who've been tested with FIT in primary care. Next slide, please. So for a recap, in 2015, fecal occult blood testing was recommended again in the NICE guidance, and at the time this was the fecal occult blood test was slowly being phased out nationally because the older form of fecal occult blood testing, the GWAIC method, had a lot of inaccuracy associated with it, which had definitely been shown through the screening programs. But nonetheless, fecal occult blood test was introduced again, for specific groups of patients. And as you'll know, these were people over the age of 50 years with unexpected weight loss or abdominal pain, people under the age of 60 years with a change of bowel habit or iron deficiency anemia, and those over the age of 60 years with any sort of anemia. And these symptoms would qualify for a fecal occult blood test, and then a positive test would lead to a qualifying for a 2-week wait referral. Next slide. But as mentioned, at that time, fecal occult blood testing wasn't available across the country. We looked into how many GPs had access to this test, and about half did across the country. So there was a bit of work to do to first of all introduce fecal occult blood testing across the country, and then also to work out which method of fecal occult blood testing was most appropriate to use in symptomatic. So the older form, the GRAC method, was being used in the screening program, and then the newer form, the FIT testing, the fecal immunochemical test, more specific to lower GI blood, no requirement for dietary restrictions or medication restrictions, and only requiring 1 sample instead of 3. So lots of positives about the test. But actually at that time, because it was a relatively new test and FIT had only really been used in the screening setting, there wasn't very much data to say exactly how it performed when used with symptomatic patients in primary care. So that's what we've been looking into over the past few years. Next slide. The first thing that we did was we compared what happens when you do an older FOB test and a newer FIT test in practice, and part of this was to inform commissioning decisions. Just wanted to show you this slide to show that the first thing that you can note from the top panel is the increase in testing over time in response to NICE guidance. So, we as GPs, we all respond to the NICE guidance, and you can see the requests for FIT for fecal occult blood testing increased over time. What you can see at the hashed line there on the right hand side was the transition between the older form to the newer form, so FOB to FIT. And the important panel is the bottom panel, which shows the number of false positive tests, and you can see that the switch from the older, less specific test to the newer FIT test shows a halving of positive tests and a lower false positive rate. So fewer people with a positive test who shouldn't have it. Next slide. Next slide, please. So at the time, the evidence was poor for FIT. NICE looked into this and found 10 studies to include in their FIT guidance, which they published in 2017. Of the 10 studies that they found and included in the guidance, there was only one that included primary care data. And actually, this was data from people who'd been referred from primary care, so not in the lower risk group of patients that we see in primary care. So not really including the sorts of patients that we need to understand how the FIT test performs. Nonetheless, they recommended that FIT should be used at a threshold of 10, and then a positive FIT should lead to a referral in patients with symptoms. And they recommended that the FIT should be used in a broader group than those recommended in the NICE guidelines from 2015, for patients with unexplained symptoms that don't meet the criteria for suspected cancer referral. Next slide. So we have a large and growing cohort of FIT tests that have been performed in primary care. So we've done some analysis on this data set. I just want to present this to you, and in a number of different ways, to present the numbers in different ways to help with this. In the end, we've got about 10,000 patients included in this analysis using the same FIT test in patients that GPs have selected, have chosen to use a FIT test in primary care in the context of the previous 2 guidelines that I've talked about. Next slide, please. You'll see that us in primary care we use FIT in a broad range of age groups. You see that the clinical indications include those sorts of symptoms explicitly included in the guidelines, but this is a real-world data set that also shows changes in practice over time. So the use of FIT in patients with raised platelets, for example, and then in increasing use in other conditions that aren't strictly from the NICE guidelines. But this data set represents the sorts of patients that we use FIT in primary care, and you can see that out of close to 10,000 patients, 105 ended up with colorectal cancer in this analysis. Next slide. So there's been a lot of debate about which threshold of FIT should be used, and this debate has certainly continued this year when deciding how to use FIT to select who should be investigated when endoscopy resources have been very limited. And so we just show here that the most important column in this slide would be the PPV slide, the PPV column. So 3% is the threshold set by NICE to trigger a 2-week wait referral. So you can see it, no matter what threshold's used on this slide, the PPV is always above the 3% threshold. So if you have a positive FIT, then it justifies referral. Next slide. Next slide, please. Yeah, thank you. To put this in different to represent these numbers in a different way, we can see the change in the numbers of cancers detected as the threshold increases. Oop. Go back a slide, please. So in the cancers detected column, you can see that increasing the threshold past 10 reduces the number of cancers detected. But reducing the threshold under 10 means that there's going to be more positive FITs to diagnose the same number of cancers in this analysis. So 10 positive FITs to detect one cancer at the threshold of 10. But within this analysis, you must realise that within every 1,000 patients tested, there'll be one patient who has a negative FIT, who has a cancer. Next slide. So this is just to point out that no test is perfect, but just to illustrate how FIT performs in relation to the other commonly used tests we use in primary care to help us decide who should be investigated for cancer. So the chest X-rays miss 20% of lung cancers. A good estimate for PSA is about 25% of prostate cancer missed with patients who have a negative PSA. CA125, there's been recent data to help us inform this, but more than 10% of ovarian cancers are missed because of a negative CA125. And so really the performance of FIT stacks up pretty well against the other tests that we use to help understand which patients should be referred for cancer investigation. But no test is perfect. So it's really important for us to remember the safety netting advice that Anant talked about with regards to safety netting patients with negative tests and persistent symptoms. And the final way to represent the impact of using FIT is to think through the numbers on this slide. So if we think about risk of colorectal cancer, so the risk of colorectal cancer in a 60-year-old with abdominal pain and a change of bowel habit works out between 1 and 2.5%. So walking into your surgery. If you were to request a FIT in this patient, their risk would increase to over 10%. And so there's no doubt that they would warrant referral. If you were to do a FIT in this patient and they would have a negative FIT, then the risk of cancer in this patient, colorectal cancer in this patient, drops to between 0.1 and 0.2%. When you consider that the underlying or the baseline risk of a 60-year-old without symptoms coming into the surgery is between 0.1 and 0.2%, you really can start to see the benefit of the additional information that you gain by taking a FIT and finding a negative test. Next slide. Thank you very much.
I was on mute there. Thank you, Brian. I think there's just a few comments that have come through on the chat box. I think Ananta's replied to Caroline's, and I think Mike Thomas has just made a mention about another paper. I don't know if you can see them up on there, Brian.
Yep, thanks. Just having a look. Is this the one? NICE guidelines are now out of date and therefore do not match current views based on it. Yeah, I'm involved in a few national discussions about this. The national advice is still to use FIT at a threshold of 10. In terms of which symptom groups, there's debate about which symptom groups should be a FIT test should be used. But
my comment was more about the paper recently published in Colorectal Diseases this month, but from the Royal County of Surrey Hospital, which is a superb paper.
Okay. What is that? Something you could link in the chat?
It's a bit further up, Brian.
Oh, yeah. Okay, cool. Yeah, thank you.
Brian, there's a question about the last question from Andy Jennings. If cancer risk of negative FIT is 0.1 to 0.2%, how does this equate to FIT missing 10% of colorectal cancers?
Oh, yeah. Well, it's so it's a difference between whether you're thinking about people with negative FITs or people with cancer. So in the group of people with cancer, 1 in 10 will have a negative FIT. But in the group of people with a negative FIT, 1 in 1,000 will have cancer. So it's depending on which way around you're thinking about it.
So I'd support that completely, Brian. So my take on this is that FIT, if the symptoms exist, then we need to understand why the symptoms are there, because the risk is very low of colorectal cancer, but not zero. So you have to assess and review the patient regularly and make sure you drill down to what the problem could be. Ask for advice, ask for further assessments, but FIT is there to actually be a very, very useful tool in the majority of cases. Fecal calprotectin, useful to help differentiate IBS from colorectal cancer in younger patients. Rachel Lambert is put in there. Maybe we should leave some of these answers to Jeffrey Lim, Karen, because Jeffrey's next to us, isn't he?
Yeah, it's perfect. We'll let Jeff do his talk, and then perhaps we can cover some of these in the Q&A part at the end. So next we'll have Mr. Jeffrey Lim, who's going to tell us a bit about the impact of the pathway changes, particularly from a secondary care perspective. Thanks, Jeff.
Hi, everyone. Can you hear me?
Yes.
Yes. Oh, great. So my name's Jeff Lim, one of the consultant colorectal surgeons. I'm joined by one of my cancer performance managers, Hazel Craig. We're here to discuss what's going on with regards to the lower GI referrals in Great Western. Next slide, please. So first off, talking about QFIT, this slide is just to show how much we're getting through with regards to the lower GI referrals. And either fortunately or unfortunately, we're not getting the majority of QFITs done. Now, the caveat to this slide is that we can't tell which of these referrals were abdominal masses, rectal lumps, or rectal bleeding. But having spoken to my consultant colleagues, we're getting a lot of referrals where the QFIT is not done for whatever reason that is. Next slide, please. This slide is a somewhat anonymized slide. Each column is a GP practice from around the region, and it's to show that some practices over this period have not sent in any QFITs. I would understand that if it was overall, most practices had maybe 40% QFITs, which meant that it was across the board that QFITs weren't being used because there was abdominal lump or obvious rectal bleeding. But perhaps something to take back is that some practices, if you're having issues with QFIT or requesting QFITs or getting QFITs, then that's something which should be flagged up. In the past, or in the recent past, I have been contacted by GPs who said they have issues requesting this, and I've had to direct them to CCG people about how it can be done. Next slide, please. This slide takes some explaining. So first off, let's look at the left of the slide. The gray in the pie chart represents 7.3%, which is all the QFITs that we have done, and we have confirmed or denied cancer. 7.3% of those QFITs had cancer. The table on the right was just an aggregate number of all the referrals we've had as of till the last week of November, the number of QFITs that we've had through, and in total the number of cancers we've diagnosed, which is 13. So that QFIT pickup rate that we've had at the bottom is different to the 7.3%, but that's just my number to show that it's 4.76%, but that's because a lot of QFITs is still in the process of being worked through whether they have or have not cancer. Sorry, that slide was a bit confusing, but I just wanted to reassure you that so far we've had QFITs, and we have not had any we have not had any QFITs which are below 10 which have had cancer. Next slide, please. This this slide was asked to be included, which is the form for asking for a FIT test. I was asked to share this with you so that you guys are familiar with this, and hopefully all the practices have this form, or if not, I presume that this can be distributed by the TVCA or the CCG so that you can get the FIT done. Next slide, please. This is a very busy slide. I do apologize. We squeezed in a 2-page referral form onto one slide, but this is essentially showing the revamped 2-weight referral form that is the latest version. Oops, there's someone waiting in the lobby. I'll just click admit. It is very comprehensive, and I'm not going to go through any of the forms, but this picture should be what you guys should expect if you want to use the latest version of the form. Hazel, my cancer performance manager, is also on the call. We can answer questions later, but I presume that this form is what will be going out through the TVCA to all the GP practices to use. Hazel, is that correct?
Yeah, well, it'll go through actually BSW and the CCG. It will, well, after this meeting, hopefully it will be going to be sent out and to get put on the Arden system as soon as we can. But just a little brief around this. We've tried to make it as automated as possible. So the square boxes that you can see can just be basically clicked on to give us that. But hopefully in the future, we should be able to get a better automation of some of that data capture. And we've tried to include everything around the NG12 guidance within it as well, along with obviously our straight to test analysis in terms of the patient and fitness in that regard. So hopefully that will help us understand what sort of patients are coming through the door when they come through. Oh, and just another thing I do need to add at the moment, just to let you know that we cannot see the QFIT test on our eye system if you request it. So that's why we actually need the actual result on the actual form. We are working on that, and hopefully at some point we should get that automated.
Thank you, Hazel. And lastly, in the last few minutes, I just wanted to talk. I've spoken to my consultant colleagues about their experience with the two-way referral. We've not had any broadly or grossly inappropriate referrals, but what greatly helps us with the straight-to-test capability is information from you guys about whether the patient can tolerate bowel prep or is willing to have endoscopy. So it greatly helps us if that box is ticked. If the box is not ticked, then we have to see the patient or triage them ourselves, which induces a delay. What can also greatly help rather than ticking the box is also to let us know their potted social history, or broadly, yeah, you can put in the referrals that we are uncertain or unable to tell this patient is fit for bowel prep. Sometimes we do get referrals saying this patient is clearly not fit for bowel prep and we prefer a CT scan or is only capable of having a CT scan, in which case we honor that request and arrange it for you. We depend a lot on you guys feeding us the data about whether a patient can or cannot have bowel prep for straight to test, which greatly simplifies things. Lastly, I was asked about whether we could put up our activity in terms of endoscopies. Unfortunately, despite our best efforts, the data that we've been able to produce is not clean enough to show you which endoscopies have been produced as part of the two-way pathway. All we can tell you is that the activity is going up. It's below the average for 2019, which is to be expected. The dip was worse in April to May, but activity is slowly climbing. QFIT will greatly help us to determine whether these patients need a two-way investigation or not. And I was also asked to say, we do have an email advice and guidance line. I am still unsure as to how this was advertised, but there is, sorry about this. It is an email address, gwh.generalsurgeryadvice@nhs.net. You can email through inquiries. Fortunately, I monitor the inbox and I usually reply within the same day, where I'm able to direct the inquiry to the appropriate consultant or at least give some advice. But yeah, the message is that QFIT helps. Please complete the forms as much as possible to help us decide and get straight to test investigations performed. And if there's queries, we have an email inbox for advice and guidance, which I usually try and respond within the day, or if not by the next day. I'm not gonna, that's it. So if there are any questions, I guess we have a session at the end, or it can be directed on the chat session.
Jeff, it's Anand here. I just wanted to reinforce what you just said, because as a GP, and I'm a jobbing full-time GP, you know, if I've got an anxiety about a patient, then the advice and guidance in whatever form it takes would be so important. And from what I've just heard from you and from discussions with you in the past recently, you've got a fantastic service whereby, you know, you've got this email and maybe Hazel, you could put it in the chat, the email address, which would be really useful for everyone. You send in information about a patient to you and you respond the same day from what you told me, or within a few hours. To me, I mean, that's a fantastic service you've got for GPs.
Okay, a few hours might be pushing it, but usually within the same day or at least the next day, I try to respond. So yeah, I've just put the address in the chat box.
Yeah, fantastic. So I mean, it sounds to me as if you've got a really good sort of communication channel here for advice, and I think this might also help with the question in the chat about. Although I'd said in my presentation that there's no point in repeating. If you're so worried that you're going to repeat the FIT test, you might as well ask for advice. But someone was saying, should we repeat the FIT test a few weeks later if required, if the symptoms persist? What are your thoughts, Jeff?
I think yes. Yes, I mean, certainly not within the same week, but certainly if the symptoms persist and you're trying to triage how worried should you be about this patient, then yes, you should repeat the FIT. And if it's positive, then initiate the 2-way referral. And if it's negative, you could still be reassured and either email, or for those who don't wish to email, you can write in. We still open our letters and usually respond back quickly. The email is quicker though, obviously. The other question which I feel I should answer straight away is from a Lynn Pearson, to be the GP QFIT. In the early period of COVID, it seems to be logistics and awareness. Lately, it has been QFIT's not done because there's rectal bleeding, at least in my experience. I'm afraid that's something which the CCG would have to poll their GPs or ask around as to what's going on. And if we get a referral from a GP that doesn't have a FIT, we will still process it because we want to ensure that the doors are open. The FITs help us, but we will not turn away GPs who are concerned about their patients. Yeah.
Jeff, there was also a question about iron deficiency anemia, 60 or under 60. What are your thoughts on that?
Again, the classic thing would be a menstruating woman who is iron deficient. I've had quite a few good referrals, and so have my colleagues, where yes, she's young, she's menstruating, but the periods are not heavy, and they have the feeling that there is something going on. QFIT will go a long way towards determining if there is loss from the GI tract, or if it's not from the GI tract. Then, if the patient is, if the GP is still concerned, they are allowed to refer in based on GP instinct. And I think there was some really good articles recently in BJGP about how to borrow Anand's use of the pun, the gut instinct of the GP is still is and always has been very valuable. I'm not hearing anything else.
So I think Mina's just put a message on saying their lack of test kit availability was an issue, which I think it was in some of the practices in Swindon, but I think that shouldn't be an issue at the moment. Just to mention that particularly for the QFIT form, obviously, has just been updated. I'm not sure if somebody else from the CCG or from the lab can let us know when those forms are now live in terms of being able to use. So I think they previously had the old criteria on them, Jeff. They had the previous FIT criteria. So there was a little bit of confusion, I think, in primary care that could they send it if it didn't have a box on the form to tick. So hopefully these forms will get rolled out soon, which should help with the uptake.
Karen, I can update on that. I sent them off to Ardens yesterday, so they should be on within the next sort of 24 hours.
Perfect. Thanks, Wendy.
If there's no further questions, we'll stay on till the end of the session. Yeah.
I'd quite like to ask Amelia if she's still there, what her thoughts are. She's the lead for the SWAG Alliance, isn't she?
Hello, yes, I'm still here. I was just typing a comment in the chat box, actually. I think it's been brilliant presentations. Thank you so much. There's a really, totally comprehensive view of everything that's going on. And we've been implementing the FIT test in SWAG over coronavirus as well. The one thing that I would say, reflection on my personal practice, is that I have really found it incredibly useful to have the FIT test. For a group of people, colorectal cancer is not an easy cancer to diagnose on the basis of symptoms. The symptoms of colorectal are extremely common, and there are many, many other causes of those symptoms, and they happen in a wide range of patients. So having broader access to FIT, I found really, really helpful. For people that I'm not sure whether it's the right thing to do, if they're frail and I don't want to necessarily put them through an invasive test, it helps me to counsel the patients about exactly what the risks are. I've had some people that I probably wouldn't have referred on a 2-week wait that have had a positive test. It's just really helping me manage the uncertainty of something that is a really tricky referral pathway. I think it's very difficult to get messages out to GPs, and there's always a gradual adoption. You have early adopters and people that are a little bit more reluctant to change. They prefer to see things established in practice. So it's understandable that this hasn't been universally accepted right across the board, but we're making really good progress as we get more experience with it. So yeah, I just for me, who has adopted it early because I've been more aware of it, I've just you know, found it really positive. It's understandable that we need to focus on those high risk patients, and there's concern that you might miss a diagnosis. But the majority of patients that will have a FIT test, a negative test, is reassuring, and there's always needs to be use of clinical judgment, but by far, as your data showed, by far the major number of these people will be people that don't have symptoms of concern and are happy to monitor or you know, not follow up at all because their symptoms have dissolved.
Perfect, thank you. I think Andy Jennings got your hand up.
Hi, thanks. Yeah, I just wanted to add a little bit of detail around the question of the forms, because I think it's probably useful background, isn't it? I think it would be fair to say it took quite a lot of to and fro within the SWAG community of the 4 different systems and to agree what the revised wording should be on the bit of paper that goes in the packaging with the QFIT test kit. So that took quite a lot of time to and fro, but that was finally resolved about a week or so ago, something like that. So whenever the next batch of those gets produced, it'll have the revised form in. What that does mean is the current kits will have the old bit of paper in there with the wrong form, but I think we're in a position where we can publicise the fact that the new one exists and put that message out to practices so they can print it off locally and chuck away the one that comes in with the kit, which should help to accelerate that process. And secondly, now that that's been agreed, one of the tasks we asked all the 3 trusts in the BSW footprint to do was to review their 2-week wait referral forms against that to make sure that they are consistent, because clearly that wouldn't be particularly helpful either if there was a discrepancy there. So that should hopefully progress that particular issue.
Thank you, Andy. And then Mike Thomas, your hand up.
Hi, Jeff, and everyone. Thanks, Jeff. That was a lovely talk. As Amelia commented, we've been aggressively trying to implement FIT into our primary and secondary care. With the increasing use of telephone conversations, we're more than happy to ring up patients who may have a negative FIT, but you are still worried about. And I think this is a really important point to get over. We find FIT really, really useful in secondary care. To try and reduce the number of colonoscopies we do. And if you look at that paper from the Royal Surrey, they reduced their colonoscopy rate from 62 to 34. That's a massive benefit for healthcare resources. So, you know, the more positive we can be about FIT testing, the better. But we will provide, you know, we're more than happy to ring up anyone you're worried about.
Thank you.
I think if it's possible, I'd just like to say, hi Mike, nice to see you again. And yes, I think I'd like to underscore what the BRI's experience is that the gates are open. If you have concerns, we will see them. We will try and triage them to the suitability of investigations, but every little bit helps with regards to, like Mr. Thomas has suggested, mobility score, and like Hazel has said, we're going to try and review whether a frailty score might help. But I think overall, the best judgment is still the GP who knows the patient right in front of them. We trust you so much. It's like, if you guys think a patient is not fit for a colonoscopy, don't tick the box, or just say so in the referral, he's not fit for a colonoscopy, or say, I think you might need to see this patient face to face, or ring them up. And like I said, we will do our best.
Just a general question, I suppose. What about those patients who are elderly, let's say, are not to be ageist, but a 90-year-old, frail, positive FIT test, not really fit for colonoscopy, not really fit for CT? What are those patients just to be managed in primary care, or do you want to know about them?
I guess it's really, again, on the GP's judgment call about whether we in secondary care can do anything for them. Now, I've had some 90-year-olds who wonder why on earth we're here. I'm at the end of my life, and I'm not going to take up a place that a 6-year-old benefit. I'll say your GP has sent you here. We will honor that, and we'll carry through the investigations that you want. But if you have patients who don't want to be investigated, then I guess patient choice. Or if you think that secondary care investigation or treatment is not going to benefit these people, again, that's something which GPs are very good, I think, at judging.
Perfect, thank you. There's a few links gone in the chat box for the article, I think, that Mike Thomas mentioned, if anyone's wanting to have a look at that. Any further questions from anybody? Any comments, Anand?
Could I just make a further comment to the question about the frail patient with a positive FIT test? I think, as probably most GPs on the call would agree with me, that we would consider and discuss with the patient the potential outcome of the test before doing it. And so if it was a patient that wouldn't want further investigation, you might discuss doing the FIT test because they might want to have a bit more certainty, although it wouldn't give them certainty, but it'd be a bit more information. But you would consider whether they were going to be for further investigation before doing the FIT test and counsel the patient at that point, I think. So hopefully it wouldn't arise as a sort of unexpected result that you didn't know what to do with. There could be situations, as I say, where you would do a FIT test without intending to refer for the results. Often patients, like to have more clarity, but only in a, there's only so far that they want to go for that. But yeah,
Karen, it's Anand here. Can I just support what Amelia just said, which is, and I was going to say this, but she beat me to it, which is, you've got to understand why you're doing the test. And, GPs are fantastic. And I'm a GP, when I do a test, I want to understand what am I going to do if it's abnormal, and it's really important to have that conversation with the patient, because if the patient says I'm not going to do anything, I don't want any investigations, any surgery, any treatment at all, I'm 90 years old, I've lived my life, etc., 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 then actually you've got to think about why you're doing the test. And I accept academically it's really useful, but there may be times when you think, I'm pretty sure there's something going on, but the patient's asked me not to. We've had a conversation, and this is where performance status comes in. So, I think it's an interesting aspect, interesting question as well. And Rachel's put in here, if you don't want to know the answer, don't ask the question.
To check that, very well. When I gave the example of that patient, that was very rare. Most of the time, the GPs in the referrals that I have are very good in stating this patient is X number of years old, but very fit and wants to know what's going on. I just want to use that example to illustrate that if you refer it to us, we will review the referral and see the patient in clinic and then take it from there. But again, I want to stress, we do trust you guys very much, and if we know that you guys see a large proportion of patients, we only see a small fraction.
And Jeff, it's Anand here again. Just to add to what you just said, I'm really impressed with the advice line and email you've got. I think that's a really great facility that's available in that area. And you've got great committed sort of surgeons like yourself who will reply, which is really great and very laudable, really fantastic. So, and then the FIT test is there to try and triage and assess the patient appropriately. So, I think the FIT is here to stay, and we just need to use it. Brian very cleverly actually had the slide about the other tumor markers we have and how they percentage-wise dictate whether it's cancer or not. So, FIT is here, chest X-rays, PSAs, etc. So FIT is doing very well. So I would really highly recommend that as part of the sort of assessment of the patient, FIT should be adopted. And if you're still concerned, get some advice. Thank you, Karen.
Thank you. Mike Thomas, is that an old hand or new hand?
I'm sorry, Karen, could you say that again?
So you've got your hand up. I don't know if that's your old hand or is a new point.
I put it down now. I apologise.
Thank you. Perfect. I think we've just had from Wendy that actually the forms aren't on the system just yet. So I will personally follow that up, particularly for the Swindon patch, but hopefully that can be also done across BSW as well in terms of the new forms being available. I think one of the key things is also that we're keen to hear from primary care as part of the CCG and all the Macmillan GPs to know what problems there are with regards to QFIT, if there's any supply issues, form issues, so we can try and rectify all of those issues as well. So if there is particular problems in particular practices, then please let your Macmillan GP know, or even your CCG GP locality lead, who can kind of try and chase those issues up. and just some useful resources there to finish off. I think we'll probably wrap everything up there. I'm sure everybody's got a load of other meetings to go to. I just want to thank everybody. There will be a feedback form that will be coming out, so please do fill that in. It helps the presenters and helps any future events that we will be doing. Any questions that haven't been answered, please send them on to Daniela. And if anyone is not on our email list, please pop your details in the chat box again so we can make sure we can send you all the information and the recording of today's session, which can be shared with other GPs in your practice as well that may not have been able to attend. Thank you very much.